athletes get injured.
Yes.
And I just want to make the point that an injury in singing is not the end of a career.
Yeah.
Athletes get injured. Singers are vocal athletes. Athletes get injured. They find out what the problem is. They rehab. They get back on the field.
Yes.
It is not abnormal. It's not your fault. It's not terrible. If you have an injury, if something's not right with your instrument, let's take care of it. Let's find out what it is. Let's take care of it. Let's get back on stage.
Yeah.
Wherever. And I think we have done a really good job over the last 10 to 15 years helping singers release themselves from blame, from injury.
Welcome to the Vocal Lab. I'm Sarah Ramsey, and it's my calling in life to help artists develop their instrument and their craft while giving themselves permission to become people they love, creating joyful lives and fulfilling careers with their own personal brand of magic.
Welcome to the Vocal Lab. Before we get started today, I want to make sure that you guys all know that this season, we've gotten very fancy here on the Vocal Lab podcast. It's true. We now have a YouTube channel, so you can find us at the Vocal Lab on YouTube. And today's episode has quite a lot of visual cues in it. So it's a great opportunity for you to check out our YouTube channel, especially if you're used to listening on an audio platform. So again, you can find us at the Vocal Lab on YouTube, or you can find the link in the show notes. So today I have here with me Sherri Zelazny. Sherri is a registered speech language pathologist with more than 35 years of experience. She received her undergraduate degree from Ithaca College in New York and her graduate degree from New York University. Sherri began her career in Laconia, New Hampshire, where, did I say that right? Laconia, where she worked for 15 years. She went on to pursue advanced clinical expertise in voice and laryngeal airway management at the University of Wisconsin-Madison Voice and Swallow Clinics. While at the University of Wisconsin, Sherri worked as a member of a dynamic team of speech language pathologists and laryngologists. She has presented nationally on a variety of voice and laryngeal airway topics. Sherri moved with her family to BC in late 2011, and she is the clinician owner of the Surrey Voice Clinic, established in 2013. Sherri's areas of special interest include voice evaluation and treatment for professional and occupational voice users. She also provides services for exercise-induced laryngeal obstruction, voice disorders in Parkinson's disease, and gender-affirming voice training. Sherri holds the College of Speech and Hearing Health Professionals BC Advanced Competency for Flexible Endoscopic Evaluation of Voice and Swallowing, and is a Lee Silverman Voice Treatment Certified Clinician. Thank you for joining me today, Sherri.
Thank you for having me.
Really happy to have you here. So full disclosure, Sherri's my speech language pathologist. So I've worked with Sherri for a number of years and is who I refer students to when I know that they need someone else to be looking on the inside, not just listening from the outside. Sherri's my go-to person. So I'm really happy to have you here today.
Thanks. Happy to be here.
Do you want to tell us briefly, for those who might, this may be their first introduction to you, a little bit about who you are and how your journey here?
I started my career I'm a U.S. citizen. I'm a Canadian permanent resident.
Mm-hmm.
I got over the border with my Canadian husband in 2011, but I grew up in New England, and like you said, I started my career in Laconia, New Hampshire. Beautiful part of the world, New England. Anyways, I love New England. And I was a general speech language pathologist there, which meant I did a little bit of everything.
Yeah.
Inpatients, outpatients, kids, nursing homes, home visits, you name it. In that first 15 years, I did that. But I knew all during that time that I wanted to narrow my clinical expertise to voice. So I started doing that during that 15 years. And actually, We were the Laconia Lakes Region General Hospital at the time. We were the first department to have stroboscopy in
Oh,
New
wow.
Hampshire. That was probably around 1999, 2000, something like that.
Yeah.
And I think we beat Dartmouth by like a day because they also got, but we were the first two facilities to actually have stroboscopy, in the state to look at the
Wow.
vocal folds. So that was pretty exciting.
Yeah.
And probably a couple years into having the voice clinic in New Hampshire, I saw an opportunity to go to Wisconsin where it was a internationally renowned voice clinic. And I just said to my husband, pack your bags because I'm going to go there and get that job.
Good for you.
And we did. And it was amazing to be able to focus like that. And
Yeah.
I can remember within the first few weeks that I was there, a referral came through for somebody who had had a stroke. And I certainly had, worked with stroke patients for 15 years. So I started to do my thing. And somebody from the department came and said, this is just voice in this department. This person was sent here incorrectly. They should be sent to this other department. I was like, I only do voice now? And it was so awesome to say. I mean, I would have loved to see that patient, but I was there to specialize in voice. So we put that person into the rehab department, and we just went forward with, people who worked there at the time were, what's the word I want? Really established the relationship between speech language pathologists and ear, nose, and throat physicians, laryngologists, Diane Bless, who was a speech pathologist, and Dr. Chuck Ford. They worked together for many years, and Diane recognized the benefit to patients of the speech pathologist and the ear, nose, and throat physicians, laryngologists working together. And it was an amazing, amazing experience to be there for nearly almost 10 years. And then we came to Surrey, we came to BC, and I found myself super, super fortunate to be able to continue in my area of specialty here. I was able to establish the voice clinic, and that's what I'm still doing, which is awesome.
That's fantastic. And you probably arrived at the right time, because I know growing up for years, I used to go to the voice clinic at VGH, and Dr. Morrison was like the only guy who did that here. And you would have been arriving probably around the time that he was pulling back and working towards retirement, right?
Right. The Pacific, what's it called? The excuse me, the provincial voice care. And now I can't remember. The provincial voice care resource program was started by Linda Ramage, who also, of course, excellent speech language pathologist in voice, and she developed this program with the province. It was the only public program in the province providing public voice services.
Wow.
And still, with some caveats.
Yeah.
The provincial voice care resource program at VGH is generally the only MSP, which is our provincial health insurance here, covered therapy. Thanks to Linda. There are other. It's very it's very complex within the public system in terms of outpatient speech therapy services, and I don't know the ins and outs of all of it. And in my very limited knowledge, if the department has some resources to provide outpatient services, they will, but if they don't, they won't. And if they do, then it's probably stroke and head injury, and it's not necessarily voice. But so I got here. Linda and Dr. Morrison were still working together. Dr. Morrison retired. Linda retired, although she's still doing some private work. But the Provincial Voice Care Resource Center is still at VGH.
So, as you alluded to, speech language pathologists can specialize in different things, or they can work in a very broad
Mm-hmm.
spectrum.
Yep.
Um, and I know lots of people are familiar with speech therapy in terms of kids who stutter or have a speech impediment of
Mm-hmm.
some sort, and that intersection. What brought you to working with the population of singers specifically? And I know you do more than singers,
Mm-hmm.
but you are one of the few speech therapists who does have a specialty in that area that I'm familiar with anyway.
I think, yeah, I mean, voice is such a small part of the profession. Speech language pathology is a very, very broad
Yeah.
profession. And voice is a very small part of it. And there's not a lot of, everybody has a voice class,
Mhm.
which is good, but really you have to do a lot of your education through continuing education and
Mhm.
mentorship and getting the right job and
Mhm.
having those things in place. And I mean, I always knew from my one of my clinical placements in my master's program at NYU that I wanted to move towards voice because it
Mhm.
was such a positive experience and just amazing outcomes.
Yeah.
And so yeah, I mean, I did a lot of work over the years to get myself in the position to get the
Yeah.
job in Wisconsin.
Yeah.
And then that experience just gave me a huge opportunity to continue to learn and um, specialize in voice. And one thing that so also, full disclosure, I am not a singer. um, but I will never forget many words that Diane Bless said
Mhm.
over the years. But one of them was, "You don't have to be a singer to help a singer."
Yes.
And I I I took that in. I wanted to
Yeah.
be able to help everybody with a voice concern. And so I can take people kind of, from anatomy and physiology and rehabilitation and let's find out what's wrong and what's happening and how is this instrument functioning
Mhm.
and how, different than how you need it to function. And I can do a little bit of crossover with some
Yeah.
voice exercises that cross over into singing, but then the goal is to get people back to their singing teachers for sure.
Mhm. Well, and I think that that is such an important relationship, and it's one that I'm lucky to be involved in an organization of singing teachers that they're very voice science
Mm-hmm.
forward
Mm-hmm.
and very and that piece gets talked about there, and I've seen it talked about. eh, well, I first came in contact with you because I heard you speak at a NATS, which is the
Mm-hmm.
National Association for Teachers of Singing. You spoke at a
Yep.
NATS event, and it was really talking about that relationship between voice teachers and speech language pathologists, and not that one was present then, but also laryngologist by
Right.
extension of that um,
Mm-hmm.
equation. And I think that's just really important to be able to, for singing teachers to recognize when somebody needs to be seen on a structural level. That is not a thing that we can do. We
Mm-hmm.
cannot provide medical advice. We cannot do any of the things. Um, but I can hear it when something isn't working in somebody's voice that sounds like it could be structural in nature,
Mm-hmm.
and it's not shifting despite all the things that we do, and that process of moving back and forth between the two, they're really complementary, and I think
Mm-hmm.
it's important for people to understand that those relationships work really well together.
Right. And with the laryngologist too.
Absolutely.
Right. I think one of the most common things, and it's definitely getting better, but over the years, one of the most common things is that singers come in because something has changed in their voice.
Hmm.
One, maybe they've never had a singing lesson. They
Hmm.
just kind of were born singing and I've always been singing and I don't know what the problem is now.
Yeah.
And they've never had any technique training. And two, and still true for many singers, they've never seen their instrument.
Yes.
And any other instrument, this is what it's called. This is what the parts are called. This is how you keep it clean. This is how you know it's broken.
Mm-hmm.
But oftentimes, many times, the first time we're looking at a singer's instrument is when it's broken.
Yeah.
And that can be a little bit tough and emotional. But yeah, no singing training, and then have no idea.
Yeah.
I open my mouth and sound comes out, and people like it.
Yeah.
And that's awesome, but no idea what's happening here.
Yeah.
And it's so important. So
really important. I actually put in my student when I'm teaching students, they each have their own Google Drive with information, so we can share back and forth. And I put a copy of a little snippet of one of my own voice scopes in there, just a little 30-second snippet of a scope, so that they can see, because exactly people don't know what vocal folds look like, and that's not even the totality of the anatomy, which we'll talk about in a minute, but people don't have any idea what it looks like. I didn't have any idea what it looked like until I had a scope down my throat.
Yeah.
Yeah. So do you want to start by going through sort of the basics of vocal anatomy, the structures involved in producing sound, what they do? Just not a lot of visual reference points for people, I think.
Sure. Yeah, first of all, the whole body's the instrument.
Right.
As you know.
Yes.
And I have often said you could stub your toe and lose your voice, depending on what kind of muscle tension patterns happen. So we'll get to the larynx, but I think it's also super important people understand injuries, motor vehicle accidents, stress, other emotional issues, concerns, trauma. There's a whole host of things that lead to changes in voice.
Yeah.
And sometimes that's the benefit of the appointment in the voice clinic, is because we'll just kind of, lay out everything that could possibly be contributing. And sometimes people don't think about other things that could be contributing to voice. So first of all, the whole body, the brain, physical, emotional, is the instrument.
Well, and I will volunteer myself a little snippet to highlight that. When my mother was first getting sick, so my mother had Lewy body dementia, and it was a very long, it was a 10-year process. It was a long process. But when she was first sick and starting to progress quite at a different rate, I started having all sorts of problems with my voice. And I knew, like intuitively, I knew that my voice loss had to do with the grief about losing my mom. And it was complicated because my mom was also a voice teacher and one of my voice teachers. So there were layers there.
Yeah,
and I had to do some counseling for a while, in order, even though the counseling wasn't about my voice, the counseling was about the other stuff, which freed up my voice.
Exactly.
Yeah.
Exactly. Sometimes we have to free up voice for the counseling.
Yes.
And sometimes the counseling needs to free up the voice.
Yes.
Absolutely.
Yeah.
Yeah. It's amazing.
Yeah.
It's amazing.
Truly.
Right.
Yeah.
But we can get to the larynx.
Yeah.
So vocal folds, everybody comes in and says, I thought they were vocal cords. It's a very old term. We're trying to get people to understand that they are folds of tissue. They're not cords like your guitar string. They are folds of tissue. You have two. They go front to back behind your thyroid cartilage. They are, I usually save this for, information in the evaluation, but they are about as long as your fingernail.
Okay, so that is even different than what I had been.
They're about 14 millimeters, 10 to 14 millimeters.
And my understanding, so as we go, if I say anything that is incorrect, please correct me. But my understanding was that it was like kids were about as long as your fingernail, women were about as long as your first digit, and men about that long. That was the
Yeah, no,
information I've
they're
been given.
10 to 14 millimeters, if I'm
Okay.
recalling correctly.
Okay.
Tiny.
That's, yeah,
Tiny,
teeny tiny.
tiny. 5 layers
Wow.
of tissue
Okay.
with the bottom layer being muscle.
Mhm.
And yeah, they folds of 5 layers of tissue.
Yeah.
Tiny, tiny muscles, huge job.
Yes.
So this part of this instrument right here, the larynx, has 4 jobs.
Mhm.
Breathing.
Mhm.
Your vocal folds are respiratory muscles because they are in your laryngeal airway. Breathing, airway protection. So if something goes down the wrong pipe, you are immediately going to cough. We've got a very complex sensory system in there that takes its job very seriously, and if anything even sneaks towards the wrong pipe, you're going to start coughing. Breathing, airway protection, swallowing. The larynx is involved in swallowing. Your larynx needs to elevate to get your epiglottis to cover the airway, and then your esophagus opens. So breathing, swallowing, airway protection, and voice. Voice is the lowest priority of this instrument, even though we call it the voice box and the vocal folds. It is the lowest priority, and if anything's happening with breathing, swallowing, or airway protection, you are going to notice changes in your voice. Even simply, very simply, you have to run to catch the bus. You have to catch your breath before you talk.
Yep.
Right? Because your brain thinks it's more important to breathe than talk.
Yeah.
So voice will always take a back seat to these other things. And that sometimes is, just a level of awareness that we have to bring people with asthma or other breathing issues, lung issues, swallowing problems, reflux. We can or not talk about reflux today.
Yeah, absolutely.
So voice is always the lowest priority of the voice box. The opening to your esophagus is also very, very close. That's why that's why things go down the wrong pipe easily. We'll see it in a second. You've got 1 second to get things once your swallow is triggered in the back of your mouth. So you chew, you swallow, food gets to the back, it triggers your swallow. You've got 1 second to get it past your airway into your esophagus. If somebody cracks a joke and you're laughing in that 1 second, then your airway opens and then you're coughing. Because it's a very, very important sequence of events that has to happen so that you don't choke. Yeah. You don't get things down the wrong pipe. We have 1 bone under here. It's called the hyoid bone. It's a horseshoe-shaped bone that all the outside muscles are attached to. I do have a picture of that.
Okay. Great.
From the base of the tongue. So I don't know where I'm supposed to show this. Here. So in this picture, somebody's sitting with it's a, drawing of the chin up. These are the floor, mouth, or base of tongue muscles right here. They attach to the hyoid bone. And then we have these extremes. So we've got the suprahyoid muscles, the muscles above the hyoid, and then the infrahyoids, the muscles below the hyoid. If this system gets too tight, you may have changes in your voice. If your larynx can't move up and down and the vocal folds can't move and things here are too tight, you could lose your voice altogether.
Yeah.
And sometimes all it would take is a little bit of massage in there to unload, lower the larynx, and people get their voice back.
Yeah.
So the other important thing is to remember that your tongue is attached to that hyoid bone. I know you and I both do a lot of tongue tension release.
Yeah.
Sometimes that makes a huge difference. We just get the tongue to let go of the hyoid a little bit, and get that space back and get the movement back, then voice gets better. Yeah. And people are often also surprised about that. Yeah. That you can stretch your tongue and then your voice gets better. Yeah. But it's because it's attached. Yeah. It's attached by the hyoid bone.
Well, and I think too, people don't have any idea how big a muscle the tongue actually is either.
Huge muscle. Right. And the part of your tongue that you can see is just a very small part of your
Yeah.
tongue. So in this picture, you can see, this is the part of the tongue that you see. And then
Yeah.
you've got all this.
Yeah. There we go.
And the floor, mouth, base of tongue, and then attached to the hyoid bone down there. The hyoid is our only floating bone. It doesn't have a joint. It's not attached to another bone. It's completely dependent on all the muscles around it for its movement.
Yeah, that's a big difference.
Yep. You've got your thyroid cartilage on the outside. And then below the thyroid cartilage is the cricoid ring. That's another super important part of the anatomy. So in this picture, we've got the hyoid bone. This is the epiglottis. This is the thyrohyoid membrane.
Mhm.
This is the thyroid cartilage where you've got the notch for the thyroid notch there. And then down the first ring. So if you want to, if anybody's watching, you just want to kind of draw your finger down over the thyroid cartilage. The next kind of bump that you come to is the cricoid ring.
So not the big bump, but the next one under it?
You've got the big bump is the thyroid notch. And then it's almost always at the first wrinkle. The cricoid, if anybody's looking in the mirror, you want to know you're in the right place. It's almost always the first wrinkle.
All right, so there's mine.
The cricoid ring goes all the way around. The importance of the cricoid ring is the muscles that are attached to it, the cricothyroid muscles.
Yeah.
These muscles allow you to go to high pitch. So this is another thing that people, almost always the complaint is, I've lost my high notes. And so there's several reasons people lose their high notes, but when there's a problem with a muscle, any muscle, flexibility is the first thing to go. And for protection, right? Any muscle, you hurt your arm, your leg, it's harder to stretch.
Yeah.
The importance of being able to stretch the vocal folds is to be able to go to high pitch.
Yeah.
You go to high pitch by contraction of the cricothyroid muscles. So when you make that first jump, it's the contraction of these muscles that pulls the thyroid cartilage forward and lengthens your vocal folds. So very often we have to get these muscles reconditioned so that the vocal folds can stretch and get through the transition notes and get to higher pitches.
So are those, when people have a lot of difficulty navigating their break, there's a lot of involvement of these muscles in that?
Absolutely.
Yeah.
Right. Right. And again, I mean, if there's been an injury or, for whatever reason, it's just that flexibility is going to be the first thing that is, it's going to be the first thing to go.
Yep.
So losing the high notes is not necessarily always the injury.
Right. It's the symptom.
It's the symptom. Right.
Yeah, that's an important piece.
Right.
Yeah, of course. For a singer, it feels like end of the world when you lose part of your range, right? But
right.
Yeah, symptom.
So here you see 1, 2, 3, 4, 5 layers. This is the muscle. You can see that pink with the red dot is the muscle. There's ligament. And then there's the superficial lamina propria, which has 3 layers, middle, intermediate, and deep. Right. And then you've got the epithelial layer, the mucosal layer, the vocal fold. And one of the laryngologists that I worked with in Madison, he would always say the top 2 layers are where the money is. And that's where the voice quality is, in the top 2 layers, in the cover of the vocal fold. And if anything interrupts the cover for any reason, stiffness, benign vocal fold lesion, scar, swelling, you're going to notice a change in quality.
Okay.
Muscle tension alone can change quality. And sometimes people come in with quality changes like hoarseness or strain or breathiness. And and their larynx is, their structure of the instrument is fine, but it's the function of the instrument that's contributing to the hoarseness.
Right.
So you can have structural or functional issues that contribute to hoarseness, but this is just a nice caricature of the layer structure that we'll see a little bit later. We'll see it move in stroboscopy.
Okay.
So this video is rigid stroboscopy with the rigid telescope that goes in the mouth. It does not bend down the throat.
Yeah. So my experience with rigid stroboscopy is so for people who haven't experienced it, you are going to hold my tongue, like you wrap my tongue with a piece of gauze and hold it. And then the actual camera, this probe, it's about sort of the, I don't know, size around of a finger, much longer than that, but it's about that size and has to get down to the gag area.
Right. Most people, excuse me, most people, even if they think they're going to gag, won't.
Yeah.
More people gag with less experienced clinicians.
Yes.
So you have to get, as a clinician, you have to get through that.
Yeah.
And get better so that people stop gagging. But it is a risk of the rigid, for sure. But lots of people tolerate it without any trouble at all.
Yeah,
which is good.
It's been fine in my experience.
Yeah,
too.
so it goes into the base of the tongue, peaks over. My rigid is 70 degrees. There's some that are 90 degrees. And everything we need to see is right there. This video that we're going to show starts with the halogen light, and then it moves to the strobe light. And the importance about that is if you go for a laryngeal evaluation and whoever is doing that evaluation does not have a strobe light,
yes,
function has not been evaluated. Yeah. Because you can't see function without the strobe light. The strobe light puts everything into slow motion. It allows us to see the layer structure of the vocal fold. It allows us to see closure. I can't tell you how many times people have come in from being scoped with a halogen light and have, the physician say, well, your vocal folds aren't coming together. But they don't know that because there wasn't a strobe light, and you can't see that detail without a strobe light. So this is going to demonstrate the difference between halogen and strobe.
And for our audience, the big reason for that is because the vocal folds vibrate so quickly. You cannot see that with the naked eye. It has to be slowed down in order to see.
Right.
That.
So average, we can just say average cis male speaking pitch is 105 to 160 hertz, which is 105 to 160 cycles per second. Average cis female, 180 to 220. Middle C is 361. High C is over 1,000.
Yeah.
So that's cycles per second of vocal fold vibration.
That's a lot.
A lot. Super fast.
So yeah, the stroboscopy is an important piece. So do you want me to start this from the beginning?
From where it is, I'm sure.
From here. Okay.
So this is halogen light. And this is strobe. So you see the difference. Now you can see the vocal folds moving. So this is stroboscopy because with the halogen, it was just a blur.
Yeah.
This is high pitch. You can tell because the muscles stretched. But this is rigid. This is high pitch. A rigid video stroboscopy. High, you can tell because the muscles are long and a little bit tighter. That it was high pitch. And so the esophagus where the food goes is just behind. I'm not going to, a point won't be there when you show the video.
So for those looking at the video, that would be towards the top of your screen.
The top behind the cartilage. There's 2 sets of cartilage there that the muscles are attached to. And so we can see, you see how there's kind of a shiny movement over the top when the vibration is there?
Yeah.
That's the cover. So
Okay.
that's the top two layers of the vocal folds. The light shines off the cover, and that's how we see it. And in some, yeah, you can see it super well. Here you can see that cover moving over the top. When we look at vocal fold by vibration, we want to see body, the muscle coming together, cover, body cover, body cover, body cover. And we look at that cover. You may have the body coming together, but if there's the cover is not moving, or there's parts of the cover that aren't moving, then we need to look further to figure out why that cover's not moving, because again, that's where your voice quality sits, is in that nice kind of water back and forth on the beach cover movement. We want to see it move about a third of the way from midline over the top of the muscle. Sometimes, you can see that there's limited movement of the covers, or maybe just part of the cover's not moving. So you've got the back moving, but then the anterior is not moving. So there's all kinds of different things that we look for with that cover moving. Sometimes it looks like the cover's it's super exaggerated, and it looks like it's moving over something. Like more cover movement is not necessarily better.
Right.
So then we want to make sure there's nothing underneath, because sometimes if there's like a cyst or something in the vocal fold, the cover will kind of wash over it. So there's all kinds of different things to look for when we look at the vocal folds.
Yeah. Do you want to look at the other scope and talk about the difference?
Yeah. So this video is a flexible endoscopy. We're taking the flexible telescope through the nose. Also very easily tolerated. I almost never use anesthetic for this, for the flex. It feels like a scope in the nose. You're going to hear me say that. In the even when we use anesthetic, it still feels like a scope in the nose. We're right here. We're at the palate.
Yeah.
The benefit of...
So that's looking at the soft palate from above?
No, this right here, this picture is looking straight back at the back. Here's the palate. Palette's coming up into view.
Oh, I see. Okay.
So she's doing some high pressure sound, so we can see how the palate comes up and in laterally. It comes up, and then there's a squeeze lateral to get the close at the back of the palate. And this is straight back nasopharyngeal wall where adenoids would have been. So now we're back down over the palate. We see the epiglottis. We see the vocal folds.
And for people's reference, which is the front and which is the back of their throat here?
The bottom of the screen is the front, where the V connects there, and the top of the screen is the back. Good question. The epiglottis is right in the front here. You can see it. So when the vocal folds form the V, breathing. So again, this is halogen. You can see some vibrato there in the pharynx. So I've asked her to swallow, because the scope, that's the only way you can clean off the scope when it's in there, is to get the person to swallow. You can see when she takes a breath. When we look at the vocal folds and when people are seeing, that's the benefit of the scope, the flexible scope, is you can do whatever you want with your voice. The rigid, you can only produce an E. You can't really sing with the rigid. So here, now we're going to turn the strobe light on, and you'll see now, you can see the vocal folds moving. And you can really see the difference between the halogen and the strobe.
Yeah, you can.
So when we look at the vocal folds and people singing, some of what you can't see here is, a little bit of base of tongue does change in the shape of the instrument for certain vowels, but you want to see the full length of the vocal fold when people are producing their voice, no matter what they're doing. So high pitch, low pitch, we should always see the full length of the vocal fold. And if we don't, we can talk about tension patterns that come in from different places that may be restricting the movement of the vocal fold and contributing to some of the problems. So she's lowered her larynx quite a bit there to get those sounds. So I'm trying to keep the scope in the same place, and you can see that the larynx moves around. But the tongue has to be, it's shaping the sound, right? That's the rest of the instrument, right? If we all cut our heads off right here, we'd all basically sound essentially the same. You got the rest of the instrument that makes the sound different. Yeah. Right? You can see how she's shaping her pharynx for the sound. Again, you know, and keeping the vocal folds in good position and not squeezing. So she's squeezing up higher in the instrument to shape the sound. Yeah.
So why don't you just say the days of the week? Yeah.
Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday.
You okay?
Yeah, it's just really music-y, I guess.
One thing I always, if I'm doing any training or, you know, teaching people how to scope is because oftentimes, you know, your patient is here, your screen is, you know, you have to be looking at the screen. You're not necessarily, you know, in maybe a perfect world, you'd have the screen right behind the patient. Yeah. But you have to remember to look at your patient. Yes. Right? Because, you know, for me, my patient is here, my screen is over here. Every once in a while, you just have to look back because people are, you know, relax your face, take a breath, you know, drop your shoulders because it's really fine. It's fine. But so, yeah, so I heard myself say, are you okay? You know, you just have to remember to look back at your patient every once in a while. Yeah. You know?
Well, and she had like really nice vocal fold closure.
Oh, yeah.
There.
Yeah.
So watching that was interesting for me because I'm used to seeing my own voice on the screen, and my folds don't close that completely. I always have a V at the top of the screen. Back.
So
an open V, to be clear.
Yeah. So the posterior gap is only a problem. So let me see if I have a good picture. I don't know. You might be able to see it here. So we all saw those bumps off to the side here. Yes. It's 3 pieces of cartilage in here that several sets of muscles attached to open and close your airway. One piece of cartilage comes down to the vocal fold. It's called the vocal process. From the vocal process back, posterior, it's called the cartilaginous vocal fold. It doesn't matter if there's closure there or not. What you want closed is the length of the membranous vocal fold. So as long as you're closing to the point of the vocal process, it's good. If you're not, if you've got more opening here, there's going to be breathiness. Yeah. You know, some loss of control, some inefficiency because that you're losing, it's a leaky valve essentially, right? On every vibration.
Yeah. Makes it harder makes breath management harder, considerably harder.
Right. Right. I mean, the other thing is to remember what we just talked about is the rest of the instrument, right? And what happens to that sound when it comes up and into this space is also important.
You want to talk about that for a minute?
Well, I mean, from where I sit, you know, we want to make sure people can breathe through their nose, that, you know, address the base of tongue tension, tonsils, adenoids. Yeah, I mean, yeah, you just have to remember that
Yeah.
again, the whole body's the instrument.
And most people end up, in my experience, like if I'm referring a singer to go and get scoped so that we know what's going on internally, they're typically someone who has never had a camera in their throat before.
Right.
But can you talk for a minute just about the value of a baseline scope, a healthy scope?
Yeah. In a perfect world,
Yeah.
that's what would happen, right? Everybody who's singing, everybody who's entering singing lessons, university master's programs would know what their instrument looks like.
Yeah.
The most important thing about that is that what does my instrument look like? Is it healthy? Am I starting with a healthy instrument? How do I keep it clean?
Mm-hmm.
What do I do to take care of it every day? And then baseline is important so you have something to compare to.
Yeah.
So if something doesn't feel right, if something happened, if you got sick and you coughed for a long time and now you feel like I've lost something, having something to compare to is so helpful.
Yeah.
And to that point, athletes get injured.
Yes.
And I just want to make the point that an injury in singing is not the end of a career.
Yeah.
Athletes get injured. Singers are vocal athletes. Athletes get injured. They find out what the problem is. They rehab. They get back on the field.
Yes.
It is not abnormal. It's not your fault. It's not terrible. If you have an injury, if something's not right with your instrument, let's take care of it. Let's find out what it is. Let's take care of it. Let's get back on stage, wherever. And I think we have done a really good job over the last 10 to 15 years helping singers release themselves from blame, from injury.
There's so much of that. And especially when you start talking about the voice as a whole instrument rather than just what happens between here and here. It is a whole body instrument.
Right.
And not an external one like a saxophone or a guitar where you're going to press a key or pluck a string.
And then put it down and not use it.
Right.
Till the next time.
Exactly.
Right?
I think that piece around vocal injury or vocal damage or any of those pieces, there's a lot of shame that goes with that for singers, and it's misplaced.
Absolutely.
Because it is not necessarily the fault of bad technique or something that sometimes these things happen. Sometimes it's your mom dying. Sometimes it's a car accident. I'm speaking all my own personal experiences here. It can be a lot of different things that play in, but they're not because you did something wrong.
Exactly.
And somehow that has been conflated for a long time.
Well, right. And I don't have a whole lot of experience here, but, certainly we know about people who have, jobs. They're in a show and they've got one thing wrong and the director says, you're out, somebody else is in, without even giving that person a chance to get better.
Yeah.
Right. And again, I think, people, in New York City and the voice labs there and done a really good job educating directors.
Yes.
And educating singers and performers and actors about, can we take care of this sooner rather than later? Don't sing through an injury. Let us know right away so that you don't end up in that position where then you can't, continue in your role or whatever. Yeah. So I think we're getting better at that. Yeah.
And I think the comparison to an athlete in sports, working in sports, is a really, really important one, because I'll tell you, if Michael Jordan pulled a hamstring, they weren't going to kick him off the...
Right. And they're not going to blame him either.
Exactly. Shit happens.
Right.
So it's okay.
Yeah.
What they are going to do is make sure that gets rehabbed.
Absolutely.
And he gets back to ones as soon as possible.
Right.
And it's the same approach that we need to be looking at
Right.
in terms of voice.
Yeah. And the other thing is lesions are not career ending.
Yeah.
I've many people that I've worked with. So again, from where I sit,
Mm-hmm.
as a speech pathologist, our best outcomes are good voice in the presence of a lesion.
Mm-hmm.
Right? If you can get your sound and do everything you want to do with your voice in the presence of a benign vocal fold lesion, awesome.
Mm-hmm.
Right? Do we want it there? Maybe not. Does it matter if it's there? No, as long as you're working with it and not against it.
Right. Right.
So I remember had a opera singer once who had a lesion, and actually she had a small, little bit of swelling on one vocal fold on the edge, and on the other vocal fold she had a what's the word I want? Kind of a pronounced blood vessel on the surface of the other vocal fold. And generally, when we see surface lesions, something on the top of the vocal fold, it's not as crucial because it's the edges that you need clear.
Mm-hmm.
But for her, that inflamed blood vessel was causing some swelling of that vocal fold. And her voice actually got better when she took care of that vessel, but she still had the lesion. She still had that little bit of swelling, and it was the vessel that needed to be managed. And she went on to perform and earn an income with that lesion.
That's really interesting, and frankly, really great news for people who are going through vocal challenges that are structural.
Right. Do we want people to have lesions? Probably not. No. But if we find that, then we're going to deal with it.
Yeah.
And I do always say we are going to figure out how to work with this instrument and not fight with it. And that makes a huge difference once you learn how to do that.
Yeah.
Right.
Do you want to just briefly talk about, and you don't have to go into huge detail, but briefly talk about the kinds of things that you would be looking for, the kinds of abnormalities that you would be looking for on a scope?
Yeah, I mean, we look for lesions.
Yep.
Nodules, cysts, polyps, swelling, blood vessels, inflamed blood vessels. We don't, like the video that we watched, pristine, white, smooth, silky vocal folds. There's blood vessels in there, but we don't see them.
Right.
When we see blood vessels, we know there's been I usually say the vocal folds are a little bit more angry than they should be because we see those vessels. So we'll look for that. We'll look for, for structural, that's what we're looking for, right? How does that mucosal wave? How does the cover of the vocal fold move? Are there any lesions? Are we seeing vessels? Is there any evidence of vocal fold scarring? Secretions, dryness, irritation of the larynx.
What about things like vocal fold paresis and
that kind of thing? For sure. Yeah, we would be, how do the vocal folds open and close? Is one not moving?
Yeah.
Is one moving not as quickly as the other one? Yeah. Paralysis, paresis, irritation in the back from coughing or reflux. Sometimes you can get a little growth of tissue back there. Then we know that there's too much pressure on the back. We can work to rebalance that.
Yeah.
And then we look at function. Range of motion. How are those muscles moving from midline? How is that mucosal layer moving? What's the closure pattern? Can we see the full length of the vocal fold when we're doing different things in there? Symmetry and predictability. So the vocal folds should move like a regular pattern, and if there's any kind of chaos in there, if they're not doing the same thing at the same time, there's going to be hoarseness, and that's what I meant about the functional.
Yeah.
So you can have some, irregular vocal fold vibration and be hoarse.
Yeah.
If things aren't balanced quite right, if there's too much tension, if the airflow's not, balanced well with the how the vocal folds are moving, if there's tension patterns, if the tongue is tight, all kinds of
Mhm.
stuff.